I'm Elizabeth Griffiths. I'm one of the leukemia physicians here at Roswell Park. My focus is on hematologic malignancies. So when we are doing watchful waiting for patients, one of the things that we do is we check the blood counts every 3 months. And if we were to see that the numbers were changing, that is to say that the platelets were moving in the wrong direction, going down, if the patient started to be symptomatic, have fevers, feel fatigued, have changes in their symptoms in terms of bone pain, in that case we would consider a reevaluation with a bone marrow biopsy. For some patients who have low-risk disease who are doing what we call watchful waiting, we might routinely check their bone marrow once a year or once every couple of years. So in that patient where I was watchfully waiting on them, if I noticed a change in the blood counts or a change in how they felt, I would pursue that by doing a repeat bone marrow biopsy and potentially repeating the molecular and cytogenetic risk profile as well as the flow cytometry on the bone marrow. And if that patient had a new change or a worsening of their blood counts and we saw a change in the bone marrow, we would consider switching gears and moving from a watchful waiting approach to either a growth factor strategy if they still had low-risk disease, or to a chemotherapy strategy followed by bone marrow transplantation if they were eligible. So patients with low-risk disease who don't have transfusion dependence are eligible for watchful waiting. That depends largely on the patient's IPSS or revised IPSS score at the time that I see the patient in clinic. So is it common? It's common for patients with low-risk disease, and it depends entirely on the type of disease that the patient has when I see them. Sometimes people are scared of watchful waiting, and they're worried that by not doing something that we are shortening their life expectancy. And I think the important point about that is that any of the treatments that we have are not, other than allogeneic transplant, are not curative. For patients who have high-risk disease, we know that without treatment, the median survival is very short, and the risk of disease transformation to AML is very high. And so for those patients, we routinely use chemotherapy. All the chemotherapies that we use, although they are relatively low dose and relatively well tolerated, still have side effects. It's my view that the longer we can get away without treating a patient, especially if they are asymptomatic and they are non-transfusion dependent, the better off we are.